All right, so hi, thank you all for joining us this afternoon for our fifth seminar that is part of our Implementation Science Education series. Kirsten Ostad and myself will be presenting on outcomes and measures. Similar to December, we want to thank you all for being flexible with the seminar format during respiratory virus season. We've enjoyed seeing you all in person and eating lunch together over the past few months and hope to be back in a hybrid format soon. But we will keep you all updated on when we can expect to do that. I also want to note that we encourage you to interject with questions and comments, raise your hand or type in the chat. We will have CIIS team members manning the chat in hopes that we can still have a lively discussion while we are virtual. And I'm Kayla. I have a background in applied medical anthropology, and I work as a qualitative research specialist here at CIIS. And I'll also be presenting with Dr. Kirsten Ostad, who is a CIIS co-associate director and from family medicine. All right, so just in case there is anyone new joining us this afternoon, we're the Evans Center for Implementation and Improvement Sciences. We're a methodological hub for implementation science in safety net settings. We offer guidance, support, and innovation in research design, and we also educate the BU and BMC community on implementation and improvement sciences. For ways to engage with us, we hold this monthly education seminar, and we really appreciate you all joining us here today. We also provide research consultations that are free. You can request a consult through our website, which is listed here on the slide. Our website is also currently being revamped, but it is and will be a great way to stay up to date on what we are doing, along with being part of our listserv, where we send out announcements for our education series, our fellowship, and other things we have going on. And additionally, these seminars are being recorded, and we recently created a YouTube channel where we will be posting the recordings. And on the slide, you can see our YouTube channel name, so it's at BU-CIIS, and this recording will be uploaded within the next few days. I also wanted to go over brief introductions. Our director is Marilyn Drainoni, who is an implementation scientist and a qualitative methods expert. And as I mentioned, I'm presenting with Kirsten Ostad, who is a CIIS co-associate director from family medicine. We also have Nick Bosch, who is also a co-associate director and is from pulmonology. Next, we have Santana Silver, who is our assistant director and has a public health background. And like I mentioned, I'm Kayla, I'm a research specialist here. Next, we have Gabby Cordova Ramos, who is a CIIS faculty and a neonatologist. We also have Catherine Fantasia, who is also CIIS faculty and is an endocrinologist. We have Shana Burrows, who is a CIIS fellow and an epidemiologist that sits in infectious disease. And we have May Ellensary, who is also a fellow and sits in developmental pediatrics. And lastly, we have Katie Rizolo, who is a CIIS fellow and a nephrologist. And like I mentioned, this presentation is the fifth in our 8-part series. The series is designed to cover key aspects of implementation science, and today we're covering outcomes and measures. But coming up, we also have quantitative, qualitative, and mixed methods, and we'll be rounding out the education series with fidelity and adaptation. And like I also previously mentioned, we send out reminders for these talks through our listserv for our upcoming talks. And so for today's talk on outcomes and measures, by the end, the goal is to be able to firstly describe core outcomes for an implementation study and to distinguish from those traditionally used in public health and medical research. The second goal is to identify psychometrically and pragmatically strong measures and methods to assess implementation study outcomes. And lastly, to understand concepts of internal and external validity regarding measures. And to get us started, I wanted to provide a definition of implementation outcomes. And this definition is provided by Proctor and colleagues. So they define it as the effects of deliberate and purposive actions to implement new treatments, practices, and services. So Enola Proctor and colleagues outlined three main components of implementation science outcomes. Like any other research study, one of the key aspects of implementation science is understanding implementation success. And for implementation outcomes, we focus on distinguishing implementation effectiveness from treatment effectiveness. So implementation measures are indicators of implementation success. And the second point they make is that implementation outcomes are proximal, meaning that they are intermediate outcomes relative to distal outcomes, such as service or clinical outcomes. And lastly, they are key intermediate outcomes for clinical outcomes because evidence-based practices can't be effective if it's not implemented well. So parsing out implementation effectiveness from treatment effectiveness is necessary to understand why an intervention failed. So did it fail because the intervention was ineffective in a new setting, which would make it an intervention failure, or because it was deployed incorrectly, so an implementation failure? And being able to answer those questions can provide actionable information that can be used for tailoring strategies, especially if it's an implementation failure. So not all implementation outcomes are of equal importance in delivery of an intervention or equal importance for research on implementation. So for example, a novel intervention, if you have a novel intervention, you might consider acceptability, feasibility, adoption, or appropriateness in that particular setting. But for an existing intervention or adaptation, your focus might be on fidelity. So do they do this as intended, or sustainability? So this slide might make a bit more sense after I go over the definitions of the outcomes, but just to note, you do have to go back to your research question to determine those best outcomes. And so if you're familiar with implementation science, I'm sure you've heard of Proctor's outcome model. It was also discussed in some of our previous sessions. So this model identifies three outcomes and three levels of outcomes. So those include implementation outcomes, service outcomes, and client outcomes, which can also be thought of as clinical outcomes. They're similar. And so the Proctor model positions implementation outcomes as coming before service and client outcomes. So with implementation outcomes, they impact the service and client outcomes. And so I'm going to go over a brief definition of each of these. So we'll start with implementation outcomes. And as I go through the definitions, you'll notice overlap between terms. And so often when you're selecting outcomes, you'll only select a few that best align with your research question. And I also want to note that implementation outcomes are widely used in this field. In some ways, it's the backbone of it too. And so acceptability is the perception of implementation stakeholders. So those could be the clinicians, the patients, or other groups. So it's the perception, their perception that a treatment, service, practice, innovation is satisfactory. And then adoption is maybe not the most intuitive definition because it's not about if they're adopting or using the innovation or the evidence-based practice, but about the intention to try the innovation. And then appropriateness is the perceived fit or relevance or compatibility of the innovation or the evidence-based practice for a given practice setting, provider, or consumer. It's also the perceived fit of the innovation to address a particular issue or problem. And then next we have is cost, and this is not the same as cost effectiveness, but the cost impact of an implementation effort. And then feasibility is the extent a treatment or innovation can be successfully used or carried out within a setting. And fidelity is like, what's the intervention or evidence-based practice implemented as the way it was intended? And then penetration is how well is the intervention integrated and how often is it used? Sustainability is to what extent a new implementation treatment is maintained or institutionalized within a setting's ongoing operations. And then efficiency is as it sounds. So was it efficient? So avoiding all types of waste. And then for safety, for the service outcomes, it's a really important outcome to consider, and it's about avoiding harm to patients. And then effectiveness, this is not the same as clinical effectiveness, but it is about providing services based on scientific knowledge to all who could benefit and refraining from providing services to those not likely to benefit. And then continuing with service outcomes. So equity is about providing care that does not vary in quality due to personal characteristics, such as gender, race, ethnicity, and so on. And then patient-centeredness is about providing care that is respectful of and responsive to individual preferences, needs, and values. And then timeliness is reducing waiting and potential harmful delays. And lastly, I have client outcomes, which can also be thought of as clinical outcomes. So satisfaction, so how do patients perceive their experience with the intervention? And then function, so how does it change function? So how does it impact an individual's ability to perform daily life activities? And then lastly, symptomatology is how patients describe manifestations of disease. And then the second model I'm going to go over briefly is the REAIM model, which stands for reach, effectiveness, adoption, implementation, and maintenance. So reach is the number or proportion of those expected to get an intervention. So how many are willing to participate in a given intervention or a program? And then effectiveness, this is the impact of an intervention on your outcome. And then adoption is like who did it, who applied the program, and where was it applied? So it's the number or the proportion of people who deliver the program or intervention. And then we have implementation. So how is something done? It's about consistency in the application, and it can also include the cost of delivery of the intervention too. And then we also have maintenance. So this is looked at over time. So this is maintaining or sustaining an intervention. So REAIM can be utilized at multiple levels, such as the individual clinic or organization or the community level. The goal of the framework is to determine the public health or population based impact of an intervention program or policy. And after briefly going over Proctor's outcome model and REAIM, I'm sure there are questions about how to select measures. And to begin to answer that question, it's important to note that there are different purposes of measurement and implementation studies. So Proctor's outcome model is important for the early phase implementation process, and REAIM is more of an evaluative model. So there's what's called gold standard measures, which are when a core outcome is the primary focus of the studies, so where you need the best possible measure and have the staff to ensure quality of measurement. We also have practical measures, which are for busier or low resource settings when it has to be brief and also feasible. So importantly, your measures that you select should follow your framework and research question. And I also recommend going back to one of our previous sessions on models and frameworks too to really connect the dots. So outcomes can be measured through a variety of ways by quantitative, qualitative, and mixed methods. Also, it's important to be specific about how you're measuring each outcome. And lastly, strong measures should be reliable and valid, which I'll expand more on in a few slides. And while talking about selecting measures, I also wanted to mention this great resource called the Implementation Outcome Repository, which is a free online resource that provides a repository of quantitative implementation outcome instruments. We also mentioned it in previous sessions as well. So it currently has 55 instruments in the repository that have been validated for the healthcare setting. So their measures follow Proctor's implementation outcomes, so acceptability, feasibility, appropriateness, adoption, penetration, and sustainability. And so for this screenshot, I selected acceptability and selected the first instrument highlighted with the red box. You can see how they provide info on the psychometric quality, the validity, reliability, responsiveness, and usability. And it's just an initial quick and useful tool to compare those instruments to across the board. And so on this screen, I went ahead and selected the first instrument, and this is the information it provides. They provide the instrument summary, how things are scored, the level of analysis, where this was applied specifically. And then this is a screenshot of lower down the page. So this is just additional information that they provide. They also link to the necessary references too. So it's just a great tool to know about. So I also wanted to touch briefly on measurement challenges. So some of these challenges are a result of implementation science being a relatively newer field. And firstly, there is uneven distribution of instruments across implementation outcomes. And as I previously mentioned, there are many synonymous terms, and this makes it hard to compare across studies, which is a common challenge across implementation science. And Catherine brought it up in last month's talk on implementation strategies too. And sometimes with measures, they're not practical or realistic to do. So it's important to consider things like time commitment. So what are you asking a patient or a provider to do? And because implementation science is a newer field, implementation measures are less standardized, and there are limited psychometric information available for most instruments. So this is a result of tools being made for local and one-time use, so they maybe haven't been tested or validated. There's also the fact that researchers rely on previously reported psychometrics that might not work for an implementation science study. And there's also limited expertise in systematic measure development. And lastly, too often studies report broadly on validity and reliability without stating the type. And when making practice change, we always want the ability to demonstrate success. And that's why it's important to pick the strongest measures for your research question. And because of this, evaluation should be part of all projects. And lastly, it's important to choose strong, feasible measures that fit your implementation gap and setting. And so with that, I'm going to go ahead and turn it over to Kirsten so that she can go over our case studies.
Great. So thank you, Kayla, so much for giving us such a great theoretical underpinning for the outcomes and measures. I think what I'll say now is hopefully what the case studies do is complicate things a little bit, because I think it can seem really cut and dry when you're reading the definitions on paper, and then applying them to your actual project can be more challenging. So definitely encourage people to chime in. And I will say that even as we were preparing for this lecture, I was emailing with some other members of our CIIS group to see like how they would define some of these things within the context of this project. So there is definitely still areas that are open to interpretation. So as we've been doing in the seminar series to date, I'm going to talk about two case examples that we've carried through the sessions, the educational sessions, so that you guys get a sense about how each of the topics relate to them. And then I added a third one that is new this time, because I wanted to be able to illustrate another use of re-aim. So the first one we're going to talk about is the case study on phenobarbital-based pathway for severe alcohol withdrawal. And just to remind people, this was a study that was done here in the ICU at BMC, and it used Proctor's conceptual model of implementation research. Next slide. So the problem that this project tried to tackle was that traditionally benzodiazepines are used as first-line therapy for severe alcohol withdrawal in the ICU setting, but they have a lot of adverse effects that come with them, like sort of sedation that requires mechanical ventilation. And so preliminary data had showed that phenobarbital had equal clinical effectiveness with fewer adverse outcomes. And so what the intervention was creating and implementing a phenobarbital-based treatment pathway for alcohol withdrawal in the ICU setting. And the two implementation outcomes that were selected were acceptability and feasibility. So I'll explain a little bit about why those two were selected on the next slide. So as Kayla talked about, this study had clinical effectiveness outcomes, which is aim 1, which is comparing the rates of mechanical intubation in patients treated with each protocol, and then also had implementation outcomes, which was aim 2. And so the main goal of this was to describe how physicians and nurses felt about the severe alcohol withdrawal management using both the traditional benzodiazepine protocol and the phenobarbital-based protocol. And so out of that aim, and because Proctor's model had been used as the theoretical framework for the project, the implementation outcomes that were selected were acceptability, again, relating to whether physicians and nurses felt like the phenobarbital pathway protocol was an acceptable alternative, and then the feasibility of it, knowing that within a safety net setting, that the feasibility of this for a busy ICU was going to be an important determinant in terms of sustainability and scalability. Next slide. And so one thing that I would encourage everyone to do is that while each of these Proctor models, as Kayla mentioned, has a standardized definition that goes with it, I think it's always helpful to make a table like this for your individual project that sort of redefines it based on your unique project. And so what you'll see in the second column here is the definition of acceptability and feasibility that the project used. So taking the generic Proctor's definition of acceptability, feasibility, and putting it within the context of it. So for acceptability, clinician perspective on the treatment pathways as safe, medically appropriate for use in the MICU, and for feasibility, the extent to which either pathway could be successfully followed in the MICU setting, with the hope that there would be some advantage to a phenobarbital-based pathway, which is a little bit more straightforward in terms of dosing and management. And so after you've sort of defined them for each of your unique project context, then you want to think about how you're actually going to measure this within the evaluation plan for your project. So as we've talked about before, a lot of implementation science uses mixed methods, and that's what this project did. So for acceptability, they decided to measure acceptability using qualitative interviews after the project's implementation with nurses and clinicians and physicians, and then based on a survey pre and post training of agreeability scales to clinicians' measured attitudes. And some example questions are provided here, both in terms of the qualitative interview guide and then the pre and post training survey. Similarly, for feasibility, they used a mixed methods approach that used both the qualitative interviews and the survey approach. And for feasibility within the qualitative interviews, they queried any ICU workflow barriers associated with using the protocols. And from a survey perspective, they talked about whether the benzodiazepine-based protocol requirement to assess patients every 15 minutes and titrate the dose on that was burdensome. Again, thinking that the more straightforward and phenobarbital pathway would be less burdensome for clinicians. So I'll pause here and see if anyone has any questions or comments or disagreements about how these two Proctor outcomes were sort of contextualized within this project. No? Okay. Feel free to unmute and jump in or raise your hand. So that's the first example. So now we can go on to example 2. So the next one is talking again about the project that was done here at BMC with the help of CIIS to distribute Narcan in the emergency department. And so this is going to be a very different example because it was guided by PARIS, or Promoting Action on Research, Implementation, and Health Services. And as a reminder about the project, this was done a few years ago before naloxone was readily available to people in pharmacies, and at that point, only 8% of people who presented to the ED with an overdose or at high risk for overdose actually received nasal naloxone at the time of discharge. And this is a very clear evidence-based way to prevent overdose deaths. And so the goal of the project was to roll out the intervention within the ED setting. So the implementation outcomes that were relevant here were acceptability and uptake or adoption, depending on how you define it, which I'll talk about next, within the PARIS framework. So on the next slide, just to remind everyone what the PARIS framework is, the PARIS framework really thinks about implementation failure or success along 3 axes: how people interpret the evidence for the intervention itself, the context in which it's implemented, and then the facilitation, or sort of how this was actually rolled out. You know, some examples being key stakeholders, clinical champions, etc. So the study question overall was, can implementing a policy for a standing order of nasal naloxone increase the distribution of naloxone kits to patients at risk for overdose in the emergency department? And so the aim one was to examine the acceptance and uptake of the nasal naloxone kit among emergency department staff. And so that's really where implementation outcomes came from, is they were baked into aim one. And aim two was to look more generally at the facilitators and barriers to policy implementation. So on the next slide, you can see, so if we take the three constructs of PARIS, evidence, context, and facilitation, and again, that same concept of taking the sort of specific context of your project and thinking about the scope and then how you're going to measure it. And in this one, most of the measurement was done via qualitative interviews. And so within the context of evidence, that included, for this definition, beliefs about naloxone and its utility for overdose prevention, beliefs about drug use and overdose, what causes that, and experience with opioid overdose prevention. And so trying to think about the two implementation outcomes that were included in aim one of acceptability and uptake, the questions that they decided to focus on were really related to those two implementation outcomes. So asking people about which part of the policy they felt like worked or did not work, what population did they feel like, again, thinking about uptake, do you see the policy focusing on, did people perceive that like they were the ones who were supposed to be taking up this intervention? What do your colleagues think about this policy, trying to look at sort of acceptance, not just for the individual person, but allowing them to comment on acceptability and acceptance of it across all sort of different providers. So that was sort of using the PARIS domain of evidence. Under context, which in this case would be the roles and responsibilities unique to the context of the emergency room, the logistical challenges that are unique to an emergency room setting, the questions that were included in the qualitative guide around acceptance and uptake were, who do you think should be responsible for ordering the kits? Again, thinking about within this specific context, which staff roles and responsibilities should be taking up the intervention. Have you ever given a naloxone rescue kit to anyone at discharge? And can you describe a scenario where you decided to give or to not give it? And then lastly, facilitation is a big part of the PARIS framework, thinking about, again, that you can't just drop an intervention into a context and expect it to magically sort of implement itself. You have to have an explicit way that that's going to happen. And so within the context of this intervention, it was understanding efforts by the hospital and within the ED to train and educate providers about the policy and how that specific approach to facilitation of training, how that may have impacted acceptance and uptake. So really asking people about to describe the training that they received in the ED around the new BMC policy and comparing that to what the plan for training was, to see if the intended training plan was actually successfully executed in this very busy context. And what overdose prevention tools would you prefer to use, and how can naloxone rescue kits become a useful tool? So thinking about, was this really the right evidence-based intervention? Would it be acceptable within this context? Before I move on, any questions about that part of things?
I have a question.
Mm-hmm.
How do you think about in the prior slide, like acceptability when you're using the PARIS framework? Is it kind of like some of the acceptability constructs kind of part of maybe the questions you're asking about context as well as facilitation and evidence?
Yeah, and I think Mary Lynn can feel free to jump in on this one. The way that I see it working is if you're using PARIS as part of your outcomes and measures, they're not well defined. And so it's a lot more what I would call squishy. And so I think that's why this one was really a qualitative based evaluation that tried to get at these things within the unique context of the intervention and the mechanism of facilitation that was chosen. But it's not going to be quite as explicit as using Proctor outcomes, which all have clear definitions related to these specific outcomes, which I'm going to sort of suggest in the next slide what could have been an alternative approach to this same project. But Mary Lynn, do you have any input on that? Mary Lynn's there.
Sorry, I couldn't unmute myself.
No worries.
After how many years? Almost 4 now? Yes, you're right. I think that what I really like this framework for kind of pre-implementation work and for thinking about outcomes, because it gave us a lot of flexibility, the team, to think through as we were starting, what would we refer to as evidence? This works really well, like when thinking about evidence, because there was a lot of beliefs and a lot of experiences of both the clinical staff, but also of patients and families. And that was a really nice one. And context also worked well, but we had to be really clear. And the distinction here between what were the logistical contextual factors within the ED, what was staff roles versus what was the facilitation. So what we did, I think, Kirsten, you're actually right. But I think what worked really well here is in this kind of pre-implementation, completely qualitative, squishy work, it gave us a lot of flexibility. We really defined these and we really stuck to it in our coding. We tried not to move around, but yeah.
And I think it, just as Mary Lynn pointed out, for your unique project, you are going to have a very specific definition about what acceptance and uptake mean in this context, but the framework does not limit you in the same way that a proctor outcome sort of limits you with a more strict definition. So definitely, if you were using these as they did for qualitative questions, your code book is going to have to define it really well, or else your consensus between different coders is going to be terrible. Any other questions about that? That was a great question, May. Thank you. So the next slide suggests a potential alternative, which didn't exist at the time that this project was done, but I wanted to bring up because I think that they are commonly discussed now. So Brian Weiner and colleagues in 2017 published a paper where they developed and validated different outcome measures for proctor outcomes for acceptability, appropriateness, and feasibility. And these are basically, each of them are 4-question, 5 Likert point scale answers that are extremely quick to administer, and so could have been feasible in the ED setting to quickly administer to people after an interaction where they gave or did not give naloxone. And so this again would have been a little bit of mixing, because your framework for the overall design would have been Paris, but then within Paris, you would have said, well, for specific outcome measures for acceptability, for example, we're going to use the AIM, the acceptability of intervention measure, which is going to pull in a more stricter proctor definition. And so this could have been an alternative approach if they decided that, for example, there wasn't the capability of doing qualitative interviews with enough ED providers to get a good sense of things. Doing a quick, 4-question scale with people would have been maybe in this context more feasible. I don't think it would definitely have given you enough ample understanding of why things worked or did not work. But just to suggest, like, this could have also been part of a mixed methods if you wanted to do both the qualitative interviews and include these standardized questions. I think a lot of people are now, as Kayla pointed out, a big limitation of the field has been the lack of standardized measures across different projects. And my hope is that with these AIM, IAM, and FIM, that we will start to have a bigger evidence pool to actually sort of have more standardized measures that can be used and compared across interventions and across sites. I don't know if anyone wants to chime in about their experience using these so far. I know one of our other CIIS faculty, Gabby, used them in her project. I'm using them in one of my projects. Again, in a context where we basically have 30 seconds with a nurse after a discharge teaching interaction, and we want to ask her what she thinks about it.
I use them a lot. I would not have used them alone here. There are times I will use them alone. What I struggle with the most is I almost always use the FIM if I'm trying to put something into practice, because I want people to tell me. I struggle a lot with using the AIM. I don't almost ever use the AIM and the IAM because I find that people get aggravated because they seem too similar. So I think it's figuring out, are you really looking at the appropriateness of the intervention? Yeah, and it's a very weird line. So I almost always use the FIM, and I usually use one or another, but I think in the best possible case, it's to do some qualitative work to understand it, to contextualize it. But I'm not sure that's not always possible. I don't know if other people feel like that, but when people get aggravated when they have to answer questions that look the same, even though they're not the same.
I agree. I think looking at these questions, I would at times have a hard time distinguishing sort of how acceptability and appropriateness are distinct concepts here. And if you go back to the Proctor definition of acceptability and appropriateness, when I read those definitions, I think, okay, I get that they're trying to hit two different things, but when you're actually, they're borne out in outcomes measures, it gets a little bit more fuzzy. So any other comments on these? I just wanted to throw these out here since they're newer and we haven't used them in any published CIIS projects yet, so that people know they exist and that they're an option. Okay. If not, we'll go on to our next example. So this is a grant application that was submitted and was not actually funded, but I wanted to talk about it because it uses RE-AIM to talk about outcomes and measures. So this was comparing implementation of a smoking cessation intervention across care locations. So the next slide will give a little bit of an overview of it. Basically, the goal of this project was to look at implementing an evidence-based intervention for smoking cessation, understanding that tobacco use is a leading cause of death in the United States and around the world. That's very preventable, and that there's a lot of evidence-based interventions that exist for smoking cessation. And this project was going to compare delivering them in two very different care settings, a primary care community health center setting versus a specialty pulmonary clinic. You know, you can understand why those would be two settings in which the issue of smoking cessation is relevant, but may have very different logistical constraints, workflows, patient populations, provider perspectives, etc. And the grant proposed using RE-AIM, and the implementation outcomes that were picked were fidelity and sustainability, which we'll talk about next. So as Kayla mentioned, RE-AIM is an acronym for Reach, Effectiveness, Adoption, Implementation, Maintenance. I actually think it's a very, very good framework, especially for something that is going to span the continuum from project planning all the way to outcome measurement, because they're very simple definitions and concepts that I think allow you some flexibility within them to define it how best works for your project. So the overall study question was whether an effective smoking cessation intervention that's targeted to long-term heavy smokers can be effectively implemented with fidelity and sustained in both the pulmonary clinic and community health center settings. So aim one was to examine which site of care could do this better with better fidelity and sustainability. And aim two was to examine differences by site and intervention effectiveness. So again, thinking about the outcomes, measurements, implementation outcomes, part of things for aim one, and the clinical effectiveness for aim two. So the next slide uses the same approach, same approach of making a table where you take your framework constructs and then you define them for your unique project and then think about what measurement sources you're going to use to actually measure those. So for REACH, the question was what percentage of eligible patients and what types of patients are likely to receive the intervention in each of these two different care settings. As you might imagine, the people who go to a primary care doctor and are heavy smokers might be different than the people who go to a pulmonologist and are heavy smokers. For effectiveness, and I'll say for that one, the sources of data that they were going to use for that was really completely quantitative. So EMR, administrative data, including the proportion of eligible participants based on the clinic population and the demographics of those, so that you could compare between the two sites which types of patients this intervention would reach. For effectiveness, the question was among intervention recipients, for whom is it effective in improving what outcomes? And so this one was going to be measured mostly based on a client follow-up of what percentage of participants report quitting smoking at 12 weeks post-intervention, and what are their demographics. So you can imagine that maybe in a pulmonary specialty clinic setting, that the people who are likely to hear and receive this message about smoking cessation might be different than those who do so in a primary care setting. For adoption, the question was what percentage and types of practitioners are likely to adopt the intervention. And I think this is one area where RE-AIM can be a little bit tricky, is how you define the difference between adoption and implementation. So adoption tends, and effectiveness, sorry. So adoption tends to be about providers taking up the intervention. If you're talking about an intervention that involves providers, where effectiveness is thinking more about the impact on the actual recipients of the intervention, which would be, in this case, patients. So what percentage and types of practitioners are likely to adopt the intervention, which would again be based on EMR or administrative data about what kinds of providers work in that clinic, what percentage of them receive the training and actually used it in delivering it to their patients. For implementation, the question was how consistently are different parts of the intervention implemented and by whom? And again, most of this study depended on EMR administrative data, so much more of a quantitative based project as opposed to mixed methods. And they planned on looking at the proportion who did the intervention, the types of staff who did it. So you might imagine that in a pulmonary clinic setting, maybe the MAs, the medical assistants, could be trained to do part of this intervention because they have a more narrow scope. We're in a primary care setting where MAs are expected to do many different types of screening, that it would need to be more provider heavy. And then lastly is maintenance. And they define that for this in terms of how well is the program and its effects likely to be maintained. And so thinking about maintenance obviously includes a time dimension. And so this was going to be looking at post-study administrative data, doing a follow-up survey with clients about the long-term effects of this, about whether a year after the project was implemented, whether providers were still talking about the evidence-based smoking cessation. I'll say that one challenge here is if you are, for example, used to using proctor outcomes and you decide you want to use re-aim for another project, there's not always a direct comparability between proctor outcomes and re-aim outcomes. And there can be some confusion at times about which ones correlate best to other ones. And so I don't think that there's ever been anyone who's done a direct comparison, but I think in general for re-aim, when I think about effectiveness, that really maps pretty well to the proctor outcomes definition of effectiveness. For re-aim, when I think about implementation, that sort of maps a little bit more closely to the proctor outcome of fidelity. And then for re-aim maintenance, for me, maps a little bit more straightforward to the proctor outcome of sustainability. But I think there can be some disagreements about that. So I wanted to open it up and see if anyone else has different feelings about mapping proctor outcomes to re-aim outcomes.
I have a question, not about that specifically, but I always wonder with like maintenance and sustainability, at what point do you consider something is sustainable or being maintained? Like, was it like a good, is there a standard, like a time frame at which you say, yes, this has been a sustainable like intervention, like a year out, 2 years out, 3 years out?
Yeah, it's a great question. Yeah, I mean, I always say as long as I have.
As long as the grant cycle.
I never try to do anything less than 6 months. I always try to do a year, but it's so hard in this study, right? Like I know a lot of people ask, like if you have a study that's 5 years and it takes you till year 4 to implement, right? So I just think as long as I have.
Yeah, and I think, one question that CIIS has worked on in some other areas is at what point is an intervention sustainable versus does it actually just become part of the culture of how care is delivered, and is there a difference between those two things? And I don't think the field has really come to a clear consensus on that yet.
Right. Kirsten, this is such an interesting issue about effectiveness, right? Because I think when Proctor thinks about effectiveness, we're really thinking about effectiveness of the implementation strategy, which is what all IS really is. But I feel like re-aim is used more about thinking about effectiveness of the evidence-based intervention. So I think that's just one of the interesting things. So you're right, it should map, but it's a weird thing because like, what are we assessing?
Yeah, and I think what's interesting here is because I would argue that the comparative effectiveness between primary care and pulmonary clinic would map to the Proctor definition of effectiveness, but just looking at an individual site's effectiveness would not map to the Proctor outcome of effectiveness, because that's more clinical effectiveness. So I think if we're in this example, if we're considering our implementation strategy to be the type of clinic where we're selected to deliver the intervention, that's the part that would really be Proctor, where the Proctor effectiveness would be parallel to the re-aim effectiveness.
Right. And when I think about reach, to me, reach maps to 2 Proctor outcomes, right? It maps to penetration And it maps in some ways to the, what is it equity? I can't remember what it is.
Equity, yeah.
Because when you're looking at the I mean, it doesn't really, but we always include the equity measure. So, you know, I love those two measures. And I feel like that always maps to the, people who are eligible who got it, and then what do they look like?
And I think that's a really important question as the field of implementation science becomes more interested in health equity, which I think those of us who went to the national sort of conference for implementation science last month came away with, is that it is a very big focus of the implementation science field, is trying to get more engaged with the concept of health equity. And so the Proctor outcomes can be attractive in that way because they include the word equity. But I think Mary Lynn's point here is important, which is that it all depends on how you define it. And I agree that within REACH, you can have sort of two different subdomains of REACH. You can have penetration into a population plus equity across different demographics.
Yeah, I think so. And I feel like CIIS in some ways has just moved to this, like, okay, let's stick a couple of measures onto some other things and now say it's like re-aim for equity or whatever. It's a little bit weird. Or the health equity implementation framework is just adding some of these quote unquote equity domains onto their frameworks, but I'm not sure those frameworks always are going to be conceptually be able to get through the path, because equity is different.
And I think it becomes very important also when you're working, as we do at CIIS, within the safety net setting, to think about equity across a lot of different domains, right? I think equity can't just be a single measure. You have to think about equity by language, equity by race and ethnicity, equity by sociodemographic group, by zip code, by all these things. In other contexts, it might be more rural versus urban. And so I think it really speaks to the need to think about these frameworks and outcomes and measurements within your unique context and how you can bend them to your will to a certain extent.
Yeah.
Marilyn, I think you mentioned the re-aim for equity and sustainability, but I did just like want to put in a plug that like many of the frameworks we use, I think have been revised in the last couple of years with equity considerations. And like, I know I am proposing to use re-aim for equity and sustainability in like, you know, some of my future projects that I am working on related to diabetes technology use, but I like the re-aim for equity and sustainability because, to your point, they specifically bake in questions about equity at all of the levels.
Yes.
Which I think is important to think about.
I think so too.
And I think, Mary Lynn, to your point that you put in the chat about whether anyone has done anything explicitly mapping across frameworks, I don't think, I've personally never seen that, but I think it's an important area of the field because it can really, as we're trying to standardize and make projects comparable, it's an important question so that we're all using the same definitions of things.
Maybe we should write it.
On it.
Idea.
Great. Well, I do want to just go to our wrap-up slide, and then we can leave some time for questions or comments at the end and make sure that people have time to go over and complete the evaluation. So the take-home point.
Karina had a question.
Go ahead.
I saw her question in the chat.
Yes. Let me just pull it up 1 second. Oh, I missed that one. Sorry. I remember when I was in, so I'm just going to read the question aloud. I remember when I was involved in a context of perspectives of use of HPV vaccines, the PI made a Markov analysis to admit how many times it could be necessary to see effective results in reducing cancer. What do you think about establishing an endpoint based on time too? For example, in my field, time to pregnancy may vary with and without the intervention or implementation. Yeah, I will be honest with you. I've never thought about that unique point of things from a Markov analysis perspective. But I think if within your unique context, it makes sense to set a time point for over what time you sort of consider sustainability or maintenance to be meaningful. And I think, you know, in a vaccine trial, for example, in a flu vaccine trial, maybe maintenance is across 2 flu seasons. That you definitely can sort of take what you know about your field and make these definitions work for it. So just to go over the take-home points for today. So the field of IS really builds on outcomes traditionally used in public health and medical research to think about not just the clinical measures, but incorporate the process of implementation. And as we think about these IS outcomes, they focus a lot more on upstream impacts and contextual factors, as well as behavior, symptoms, or diagnoses. And that this whole field of measurement development is relatively new and an area that needs a lot more research and growth. But the current reality is that it really does limit the number of psychometrically strong tools that are available to those of us trying to do IS research. And lastly, that balancing rigor and pragmatism and outcomes measurement is an art as much as it is a part of an IS skill, and that always asking others for input, I personally find to be helpful in this process. But in the end, you are the expert in your context. And so being realistic about whether this type of outcome or measurement is going to be feasible within your unique context is a really important question, because it's better to get data that might be somewhat limited, but that you can actually feasibly collect, as opposed to sort of shooting for the moon and coming back without any good data. So on that point, we will put up the QR code for the evaluation for these sessions. Please take the time to fill them out. We very much value your feedback and really do change future educational seminars based on the comments that people leave. And then I'll open it up for any last minute questions or comments. And we hope to see all of you guys at our next session on February 8th, same time, 1 to 2, and we will be in touch based on COVID and flu data about whether we'll be back in person, hybrid option, or Zoom only. All right. Well, if there are no last minute questions, I think we'll go ahead and wrap up. And if you guys do have any after the session, feel free to reach out to myself, to Kayla, to the CIIS website question forum, so that we can go ahead and answer any questions that come up for those who are maybe watching it the recorded version.
Thanks, everybody.
Thank you. Bye-bye.
Okay, thank you.